then started the presentation.
Okay, perfect. Morning, everybody. I'm Leila Mahomed. I'm one of the registrars in the department at UCT. And this morning, I'm going to be presenting a pediatric topic, which is otitis media with effusion in children, which is a condition so common, it's actually been dubbed an occupational hazard of early childhood, which I thought was quite funny. So I'll just jump into the presentation. So this is a brief outline of what I'll be going through. So I just wanted to provide an update to us clinicians regarding the actually quite favorable natural history of most cases of OME. Also to identify any kind of improvement measures we can implement in managing our patients with OME, how to improve our diagnostic accuracy. Also, what's quite important is how to identify children who are most susceptible to any developmental sequelae from OME, and also special groups and the specific management pertaining to those conditions, and also the lack of clinical benefits for certain medical therapies which have come to light, for example, steroids, antihistamines, and decongestants. So OME can be described as a closed space inflammatory process occurring in the middle ear, and it's not infective. It's the greatest incidence is in the first 2 years of life, and this is thought to be because of immaturity of immunological defenses and also eustachian tube dysfunction, and also the immature structure of a pediatric eustachian tube. The diagnosis is generally based on clinical signs, and it can be supplemented with audiological testing. And it's important to have up-to-date clinical guidelines because it's a condition of high prevalence with significant practice variations in management that have cropped up over the years. Just going further into some definitions. So otitis media with effusion, or OME, is the presence of fluid in the middle ear without any signs or symptoms of infection, which is important. And then AOM, or acute otitis media, is the presence of fluid in the middle ear with the acute onset of signs and symptoms of middle ear inflammation and infections. And synonyms for OME are ear fluid or serous effusion, secretory effusion, or non-suppurative otitis media. And I thought this image quite nicely illustrates the differences between the two. In terms of pathophysiology, so what is a glue ear? It's described as a collection of fluid in the middle ear cleft associated with effusion, and it occurs generally as a result of eustachian tube dysfunction. So you then get inadequate middle ear cleft aeration, which results in hypoxia. You then get mucosal inflammation, an effusion then develops, and then there's impaired mucociliary clearance of this fluid. And this has to do with the relative degree to which air is absorbed by the mastoid mucosa. And this means that fluid has to fill the space to buffer against this change in pressure that has occurred. In terms of the healthcare burden, this is significant. So otitis media is a very common reason for OPD visits to pediatricians globally, and it actually accounts for 1 in 9 office encounters in primary care practices, which if you think of the scope of pediatric conditions, this is high. And of these, about 1/3 are for OME. And despite the frequency of OME, the surveillance data suggests that the minority of clinicians actually follow the and only about 1/3 of them will obtain an age-appropriate hearing test when the effusion is persistent for more than 3 months, which is the general recommendation. And then additionally, more than 30% will treat OME inappropriately with antibiotics or ototopicals, and this creates a potential for unnecessary adverse events and also bacterial resistance in the pediatric population specifically. Carrying on with the epidemiology, so the overall prevalence of OME in Africa has been cited as about 6%, which seems quite low, but 90% of children develop OME before school-going age, and on average will experience about 4 episodes a year. The highest rate of OME occurs in the 0 to 4 year group, and there's a bimodal age distribution. Occurring at about 2 years and then again at about 5 years. The prevalence of OME in children with certain syndromes, for example, Down syndrome or even a cleft palate is much higher. It's in the range of about 60 to 85%. And then there's several associated factors. So age less than 4, a cleft palate, as I've mentioned, any craniofacial abnormalities, type 2 diabetes, so that's on the line of immunodeficiency, also low CD4 count in the setting of HIV, patients with allergic rhinitis, and also adenoid hypertrophy in children younger than 5, which we also know is very, very common. In terms of the etiology, so it occurs, as I've said, when fluid builds up in the middle ear space, which is a normally air-filled space. It may also occur during an upper respiratory tract infection or spontaneously because of eustachian tube dysfunction, or it could be an inflammatory response following an episode of acute otitis media. More on the eustachian tube. So as we know from anatomy, the eustachian tube in a child is much shorter. It's also more kind of floppy. Has poorer tone. It's more horizontal, as you can see from the image, and it's therefore much less effective in ventilating and protecting the middle ear than the eustachian tube in an adult. Further on the etiology, so there's several kind of etiological factors that have been cited: genetics, environmental factors, as I said, eustachian tube dysfunction, infection and immunity, and also upper air digestive tract inflammation and ciliary dysfunction, which I'll go through in a bit more further detail later on. So the natural history is quite favorable in general. So most episodes will resolve spontaneously within 3 months. However, 30 to 40%, so close to half of all patients will have recurrent OME, and then a further 5 to 10% will in fact have persistent OME more than 1 year. And then this is where the concern arises, because it's associated with significant hearing loss. They get vestibular problems, poor school performance, which is extremely significant, behavioral problems, which ties in with poor school performance, ear discomfort, which can be very, unacceptable, could be unacceptable for a child who's expected to perform at school, etc. When they've got this persistent discomfort or pain. They can also get recurrent acute otitis media as a result, and all of these then lead to a reduced quality of life for a child. Less often, OME can also cause structural damage to the tympanic membrane, and this might then require surgical intervention. So the subtypes of a middle ear effusion have been classified as either eosinophilic, it can be as a result of recurrent acute otitis media, can be a retraction, or even CSF. So eosinophilic middle ear effusions are quite infrequent and happen serous effusion. So it's a very viscous effusion, and there's therefore a much higher rate of discharge after grommet insertion. Children often have a failure to improve, and it's more actually commonly managed with hearing aids. And then I just wanted to also mention CSF. So this is something we should be aware of, especially working in a pediatric hospital where children often have multiple pathologies or background medical conditions. So there should always be borne in mind that when you see a unilateral crystal clear fluid and laryngotomy, then you've possibly created an iatrogenic CSF hook. Clinical presentation, so they present with a conductive hearing loss, and the presentation is related to the hearing impairment and the effects of this. So they've got hearing impairment, and as a result, they'll have speech or language developmental delays, and then they can also be associated presentation. So they might have recurrent otalgia, or mom might complain that child's always got features of an upper respiratory tract infection, or has an ongoing kind of leaky ear. They might have poor school performance and lack of concentration or attention, and even balance difficulties as a result of vestibular dysfunction. So in terms of diagnosis, it's quite straightforward, but I thought it's well worth mentioning and emphasizing. So pneumatic otoscopy is recommended as the primary method for diagnosing OME. And the reduced mobility of the tympanic membrane correlates very closely with the presence of fluid in the middle ear. OME should always be distinguished from an acute otitis media, and that's based on the color, position, mobility, and just general appearance of the tympanic membrane. And then just pure pneumatic otoscopy has a sensitivity of 94% and specificity of 80% versus myringotomy as the gold standard. And it's obviously far less invasive, it's readily available, cost effective, and it's very accurate, and we should all be proficient in this. And then in terms of audiological testing, so tympanometry should be done when the diagnosis is uncertain, and this is after you've attempted pneumatic otoscopy. And this is done by the audiologist. It's painless and very simple to perform. It can also be done with a screening unit, which is very useful. And in terms of a formal audio, the NICE guidelines in the UK have suggested that a hearing loss of more than 25 to 30 decibels at a 3-month interval implies that grommets, you should consider insertion of grommets. So the degree of hearing loss, there's been a lot of work done at the Cambridge University on the middle ear mechanics and how the tympanic membrane moves and how the middle ear effusion changes this. However, it's actually the degree of hearing loss that we see in OME is very variable. And this variability is not actually easy to explain. So you can see children with hearing loss of minor hearing loss, and you can also see children with significant hearing loss. However, several reasons have been proposed. So the viscosity of the fluid, it seems kind of obvious that that this might be important or significant, but this has not been borne out in any of the studies. Whether there's any aeration at all in that middle ear cleft. The anatomy of the tympanic membrane, so its position, retraction, all those kinds of things. And then also the middle ear mucosa. So inflammation of the middle ear mucosa impedes vesicular function and might contribute to a worse degree of hearing loss. Just a note on screening for OME. So according to multiple guidelines globally, population-based screening programs for OME are not actually recommended in healthy asymptomatic children. It's a highly prevalent condition in young children with up to 40% point prevalence in healthy children younger than 5. And screening has not actually been shown to influence any short-term language outcomes. There's been no benefit from treatment that exceeds the favorable natural history of the disease, as I mentioned earlier. And there's also a risk of inaccurate diagnoses or over-treatment or creating parental anxiety, and also increased cost because it entails equipment and staff resources. Hearing and language, this is exceptionally important. So hearing testing is recommended when OME is persistent for 3 months or longer, or at any time when you pick the following up during your follow-up of the patient. So if there's any language delay or concerns from the parents, if there's been reports of learning problems, feedback from school teachers, if there's any suspected significant hearing loss in a child, so any suspicion of a significant hearing loss in a child with OME. And then language testing should be conducted for children with any proven hearing loss, and extended periods of conductive hearing loss can result in developmental and academic sequelae, as I mentioned earlier. Just a note on recurrent acute otitis media. So the most recent systematic review actually recommends long-term low-dose antibiotics. However, the NICE guidelines in the UK are quite a bit more conservative with antibiotic prescription, and they recommend that we don't give antibiotics, and we rather insert tympanostomy tubes. In terms of antibiotics, there's been a small reduction in acute otitis media cases, and also so that hasn't been thought to be significant. Also, the cost can be high. There are potential side effects, and of course the big issue of bacterial resistance. And then in terms of tympanostomy tubes, you get reduced recurrence of the effusion or of the frequency of the episodes, and also total recurrence time is reduced. So who is the at-risk child? These are children who we should identify early. So we need to distinguish the children with OME who are at risk for speech, language, or learning, with OME who are not at risk. And these children should be more promptly evaluated in terms of their hearing, speech, and language, and also the need for early intervention. So issues are permanent hearing loss, if they have any kind of disorder that's associated with a speech and language delay, if they are on the autism spectrum already identified, if they have any syndromes with any cognitive impairment, if they have syndromes associated with blindness, cleft palate patients, and any other developmental delays. So when can we opt for watchful waiting? So these are for children who are not at risk. So watchful waiting for 3 months is from the date of effusion onset, if this is known, or from the date of diagnosis, which is more common. It's more common for us to be making the diagnosis. And OME, as mentioned, is usually self-limited. Up to 90% of OME after an acute otitis media will also resolve spontaneously by 3 months. And waiting results in little harm to the child if you have a good follow-up plan. And we need to then, in the interim, optimize the listening and learning environment until such time as we've evaluated that the effusion has resolved. To mention another important thing, which is single-sided hearing loss. So historically, this wasn't actually considered to be an issue because it was unilateral and it was thought that the other side would compensate. However, it is thought to be relevant, especially when long-standing. So the evidence suggests that these children do actually have poorer academic performance. Their listening effort is much greater. Their speech in noise is also a significant point, and these children are school-going age, so they're in a classroom. Very important implications for educational outcomes. A note on hearing aids or hearing augmentation. So these should be considered in patients with persistent bilateral OME with hearing loss, where surgery is contraindicated or not accepted. Moving on to medical therapy, so things like oral steroids or prolonged intranasal steroids, antibiotics, oral or topical, antihistamines, homeopathy, mucolytics have all been kind of mentioned in various studies, but guidelines are unanimous in that they are ineffective for the treatment of OME and are not actually recommended for treatment. Antibiotics and systemic steroids don't have any long-term efficacy and aren't actually recommended for routine management. The studies do show that they have some short-term small magnitude benefits, but there are significant adverse effects, especially if you're giving systemic steroids or antibiotics. And then a short course of an intranasal steroid can be considered in children with OME, and also if you've evaluated them as having concurrent adenoid hypertrophy or allergic rhinitis sinusitis. There's no role for topical antibiotic or steroids in treating OME. Other treatments, so there's alternative medicines and also allergy management. There's actually no recommendation for either of these. There's few studies and poor evidence. And also another thing is that some of these medications are unregulated. So the safety, especially in the pediatric population, might not yet have been fully verified. So specialized groups, I mentioned this a bit earlier, so I'd like to go into more detail now. So groups include those with Down syndrome or trisomy 21, patients with cleft palate or lip, any and also those undergoing assessment for cochlear implant. So anyone with immunodeficiency, we actually manage him as normal, as per normal with grommet insertion at the appropriate time. Any craniofacial abnormalities, so here we might want to consider a long-term grommet because the rate of extrusion of conventional grommets and the rate of recurrence has been said to be higher. Children over 12 are a special group because the guidelines are specifically for those less than 12. So should we manage those above 12 as adults? Should they be managed as pediatric patients? I think this is, from what I gained from the literature, is that it's a clinician-based assessment. So it needs to be done on a case-by-case basis. And then those undergoing cochlear implant assessment. So the whole thing here is that you aim to assess these children in a timely fashion for a cochlear implant. And usually, I think internationally, they say 9 months to a year, which is very early. So their recommendation is that you rather treat the middle ear effusion early on than wait for the glue to clear in order to not delay the assessment for the cochlear implant. So moving on to PCD, or primary ciliary dyskinesia. So this is an autosomal recessive disease which is characterized by abnormal ciliary structure and function. It's associated in about 50% of cases with situs inversus, which is why I put this chest X-ray up. So important to do a chest X-ray and make sure there's no dextrocardia. Although that they might have PCD and not have dextrocardia, so that should be borne in mind. The important to us is that the otologic features in these patients are generally explained by their defective ciliary function within the eustachian tube and middle ear cleft, and this impairs mucociliary clearance, and this specifically can present with acute otitis media or recurrence of this, or OME. And generally, all studies have shown that grommet placement has failed to improve the middle ear condition. And so if you are suspicious of this condition in a child, you rather work them up, manage them conservatively in the interim, and it's a multidisciplinary team workup. And only once the condition has been excluded should you proceed with tympanostomy tube insertion if indicated. And then moving on to cleft palate and trisomy 21. So both of these conditions should be managed as part of a multidisciplinary team. Hearing assessment should be done early and then 6 monthly in these children according to guidelines. This might not be achievable in all resource settings, in poorer resource settings. To perform the ventilation tube insertion early at the time of cleft palate repair, when the ABR level is shown to be more than 25 decibels. However, we do know that the outcomes are worse and there is a higher rate of persistent glue in these patients. However, on the other side, cleft surgery improves eustachian tube dysfunction. So you might find that as the child grows, and after the surgery, you will get a resolution anyway. And then hearing amplification can be considered, or hearing aids can be considered as an option in cases of mixed or especially if the child is quite small, are significant. They also, if they have a mixed hearing loss, or you can consider hearing aid as an alternative to a ventilation tube insertion. And you consider grommet insertion in Down syndrome with OME after weighing the risk and benefits, but this is for all special populations. So moving on to the indications for surgery. So OME persistent for more than 4 months with persistent hearing loss of more than 25 decibels at a 3-frequency average is an indication. If you get recurrent or persistent OME in an at-risk child, or OME with any structural damage to the tympanic membrane or middle ear, but this should be carefully evaluated, especially based on the child's age, if they're in a special population, etc. And then this image just shows the steps of inserting or performing a laryngotomy and then inserting a tympanostomy tube. So a laryngotomy with grommet insertion is the procedure of choice. It's a very safe procedure. There's multiple options in terms of what kind of tube you insert, but this should be discussed and is very dependent on your intention and the duration of which you would like the tube to stay. Combined adenoidectomy should be considered in children with persistent OME if they have hypertrophied adenoids. And repeat surgery will the recommendation is that you should then do an adenoidectomy plus myringotomy with or without tube insertion. And then a tonsillectomy alone or myringotomy alone should never be used to treat OME. So in terms of surveillance, so children with persistent OME who are not at risk should be re-examined at 3 to 6 month intervals until you've excluded or until the effusion is no longer present. There's significant, or if in that time you identify significant hearing loss, because then you shouldn't take a watchful waiting approach, or you should act on that rather, or if there's any structural abnormalities to the tympanic membrane or middle ear. The resolution rates decrease the longer the effusion has been present, and these are the risk factors for non-resolution. So seasonal, so summer or autumn to winter, if the hearing loss is more than 30 decibels, if they had any adenoidectomy. So more on adenoidectomy. So the research is quite mixed regarding the benefits of grommets and adenoidectomy for chronic otitis media with effusion. It's generally not recommended with the first set. However, if subsequent sets are needed, the benefit is marginal. So where the indication for adenoidectomy is OME rather than obstruction, then the size of the adenoids is not actually relevant as an indication for its removal. And the MRC target trial, which highlighted alternate regimens in glue ear treatment, showed that it actually supported the consideration of an adjuvant adenoidectomy in children over 3 undergoing ventilation tube insertion. Okay, moving on to the post-op care. So the complication rate is usually underreported. However, about a quarter of patients will have otorrhea, 1 in 20 will have early extrusion, and it's important to know that routine antibiotics are not indicated routinely. So the follow-up strategy, so it's recommended to be 6 monthly according to the guidelines. At Red Cross, we generally do a 3-month follow-up for the first post-op visit, and we do TIMPs and an audio on that visit, and thereafter we assess how often the patient should come. It's generally 6 monthly to yearly. Advice to parents is very important because there can be certain issues that crop up for which they might need assistance. So dry ear precautions, are they recommended or not? So the evidence is quite limited, and a number of guidelines actually recommend against water precautions. However, what they do say is that you should discuss the risks and benefits with each patient. And the thinking is that keeping the ear dry prevents onset of infection. We should avoid instrumentation, and this causes bleeding, pain, or any injury to the tympanic membrane. If they get a discharge or infection afterwards, it's actually quite common, 15 to 20%, and they say it's because of getting water in the ear. So this is evidence for supporting dry ear precautions. However, it can also be from an upper respiratory tract infection, and most of these discharges will respond to ciprofloxacin and eardrops. Extrusion, so they should extrude in about 6 to 9 months after insertion. It can be more, it can be a bit less. Granulation tissue at the site of the grommet, and it may need treatment with an antibiotic or, if persistent, removal of the grommet and an EUA. So in summary, it's a very common condition, as I've mentioned. It's got quite complex pathogenesis, even though it's reduced to kind of a short consult generally, because because of time and because of how common it is. It's actually quite a complex condition. There is very clear guidelines on its management for the vast majority of patients, and even for special groups. And we should always consider each patient carefully, and not because we've seen so many of this condition treat each patient the same, because there are special groups that will arise, and some of them may need different management or special management. Okay, thank you. These are my references.
Thank you, Leila, for a very thorough, good presentation. I think it's a condition that we often don't really think about too much because we see it so often. So thank you very much for that. We have any comments from the audience? I don't know if there's any consultants from Red Cross on the talk this morning. Any comments from the floor?
I'll comment. Thanks, Leila. That was a very comprehensive talk. I'm not sure, just one or two things. I'm not sure if you mentioned that what frequency are you using to define recurrent acute otitis media in terms of potential indication for grommets?
Sorry, I couldn't hear quite clearly.
So I was just clarifying, I'm not sure if you mentioned it and I missed it, but what frequency of acute otitis media are you using in terms of your definition for recurrent acute otitis media as an indication for grommets?
You mean in terms of the frequency of the episodes?
Yeah.
No, I didn't actually mention that.
Do you know what it is?
No,
so we normally use more than 3 episodes in 6 months, more than 4 episodes in a year.
Okay.
As a potential indication for grommets.
Okay.
And then just a few other kind of practical things. The role of adenoidectomy, when I last saw the American Academy guidelines, unless it's changed, they advocate for an adenoidectomy if the child's over the age of 3, but that can obviously is slightly controversial. But obviously a child who has associated obstructive symptoms like snoring and any symptoms suggestive of sleep disordered breathing should have an adenoidectomy as an adjunct. And then just a practical thing, because I get asked this from time to time from the registrars, is what you do if you have a dry laryngotomy. Have you read anything about that?
So, so I think, so if clinically you suspect OME, and if you don't have, for example, access to an audio, there is, it is acceptable to then take the patient, so this is obviously if you've made the clinical assessment in kind of, so the patient has hearing loss or speech delay, and clinically the tympanic membrane has features of an OME. So it is acceptable to take the patient then to theatre and without any kind of hearing testing or TIMPs done, and you perform laryngotomies, and if you find fluid, insert grommets, and if you have, if there's no fluid on your laryngotomy, it's acceptable to then leave it at that. So there's no need to insert the grommet hearing loss or speech delay. Yeah.
Can I ask if you have a patient that has recurrent acute otitis media, so they meet the criteria for a grommet, and you go in, and at that stage the laryngotomy is dry, is it acceptable then, because of that history, to put in a grommet?
Yeah, so I asked the same question when I was a registrar. And I think that, if I remember correctly, the guidelines say you should put the grommet in even for acute otitis media if there is fluid in the inner ear, and if it's dry, probably not. But I was told at the time by the paediatric otologist that we should put the grommet in. I think on average it reduces 1 episode of acute otitis media every 6 to 12 months. And also, if they do get a subsequent episode, it's usually better tolerated by the child because the ear can decompress. But I think the literature is a bit hazy there.
Yeah.
We've had one comment from the gallery that have said, in my practice, grommet insertion at the time, even when dry.
Okay.
And then on dry air precautions, I thought, I mean, you've obviously read more than me, but I don't advise my kids to, I don't advise them to scuba dive, but I thought it was safe to swim and what have you, because the surface tension is always prevents water from actually getting in the ear. And I think it's actually soapy water, which can be potentially problematic because that reduces the surface tension.
Yeah, so also there's quite a lot, and it's and quite a lot of conflicting stuff. Most of the guidelines are not strict about it. So, however, there is this concern that getting water in, and I think you're right. Yeah, it is specifically soapy water.
Vincent, you can unmute yourself.
Hi, Shavina. Sorry, my internet's a little bit dodgy. Yeah, thanks, Leila. I missed a big part of the talk, but I think it's a very common condition that so many things are actually quite controversial, like the placement of grommets in the recurrent otitis media. The evidence for that is actually quite poor, and like Matt mentioned there, it just improves the tolerance of recurrent infections, but it doesn't. The evidence to show that it decreases the amount of times they get infections is actually quite poor. And then the water thing is also very controversial. What I was taught was that you shouldn't allow them to swim in stagnant water. So free river water or seawater is fine, but not in dams or, you know, basically dead bodies of pools of water that is not treated. And then obviously soapy water can also be a problem with that regard. Yeah, and I mean, the evidence actually shows that the benefit of putting grommets after a year is only about 6 decibels improvement of hearing loss. So yeah, it's a very common thing that we see, but there's a lot of different ways that the condition is being managed. I also have it as to do an adenoidectomy in children of the age of 4 and older, shows decreased rate of getting OME. Now, is it also because of the adenoidectomy, or is it because the maturation of the eustachian tube? So yeah, it's a lot of things up in the air, but thanks for a good talk.
I think Vincent, just Rosenfeld, who's obviously is a big person on middle ear effusions, he gave us a talk at a congress a few years ago, and he's been on all those international consensus panels and American Academy guidelines. He's done a lot of work on middle ear effusion, and his take on the recurrent otitis media, and I mean, he was very, very open and honest about it. He said, you know, even though the evidence is poor, in reality, when you're faced with that patient and they're coming back every 2 months, more often than not, and this is the guy who's written all the consensus guidelines, and written, you know, he's putting grommets for those kids, simply because it's like you've got the patient right in front of you, and they're coming back every single time, every 2 months with recurrent acute otitis media. I mean, that's just a comment. My big concern is with the different management, and I know in the UK there's papers on sort of using hearing aids and letting the child grow out of it, whatever. My problem is always when you don't insert grommets and you're left with this persistent middle ear effusion, the retraction, the constant middle ear effusion and retraction that occurs, it's not all of them, but those patients who don't resolve, you end up with a very, very, and I mean, we've all seen that the eardrum eventually becomes so atrophic, it doesn't support a grommet eventually if it's left. And the other thing is the retraction. And so and the problem is you can't tell which patients those are, you know, which of your patients are going to go that route. That's the concern. And so I think someone with a persistent middle ear effusion, I've always, you know, and this is completely off record now, I'm not comfortable with leaving a patient like that without having a grommet inserted, simply because I've seen patients long term, and those patients obviously, you know, need long-term grommets, and then I put in T-tubes for them. And in those patients, it's amazing. You might not, sometimes the hearing loss doesn't reverse completely, but definitely the effect of the ventilation on that, on the status of that tympanic membrane makes a big difference. So, yeah. I mean, I think there are a lot of gray areas and a lot of controversies in this, and sometimes the guidelines help, but I think when it comes to the person in front of you, then you know, you've got to make it.
Thank you, Prof. Harris. Is there anybody else on the floor that'd like to make a comment? Thank you, Leila, for a great talk. I think we will conclude the meeting for this morning. Thank you, everybody. This is our last talk for the year. So I hope everybody has a good festive season, and we'll see you in the new year.
Thanks, everyone.